Calcium imbalance. Introduction. Calcium plays a major role in transmitting nerve impulses and helps regulate muscle contraction and relaxation, including cardiac muscle. Calcium is instrumental in activating enzymes that stimulate many essential chemical reactions in the body, and it also plays a role in blood coagulation. Because many factors affect calcium regulation, both hypocalcemia and hypercalcemia are relatively common disturbances. The normal total serum calcium level is 8.6 to 10.2 mg per deciliter, 2.2 to 2.6 millimoles per liter. Calcium exists in plasma in three forms: ionized, bound, and complexed. Calcium imbalance is divided into two: calcium deficit, hypocalcemia; calcium excess, hypercalcemia. Calcium deficit, hypocalcemia. Hypocalcemia, serum calcium value lower than 8.6 mg per deciliter, 2.15 millimoles per liter, occurs in a variety of clinical situations. A patient may have a total body calcium deficit, as in osteoporosis, but a normal serum calcium level. Older people and those with disabilities, who spend an increased amount of time in bed, have an increased risk of hypocalcemia, because bed rest increases bone resorption. Pathophysiology. 1. Primary/surgical hypoparathyroidism. Reduced parathyroid hormone impairs calcium regulation, common post-thyroid or parathyroid surgery. 2. Citrate blood transfusion. Citrate binds ionized calcium, temporarily reducing levels. 3. Pancreatitis. Lipolysis releases fatty acids, forming calcium soaps. Glucagon-induced calcitonin secretion exacerbates hypocalcemia. 4. Renal failure. Hyperphosphatemia leads to reciprocal hypocalcemia due to calcium phosphate imbalance. 5. Vitamin D deficiency impairs calcium absorption. 6. Other causes: magnesium deficiency, medullary thyroid carcinoma, low albumin, alkalosis, and alcohol abuse. 7. Medications. Drugs like loop diuretics, aminoglycosides, and corticosteroids interfere with calcium metabolism. Clinical manifestations. Tetany, increased neural excitability, causing sensory and motor symptoms. Chvostek sign, facial muscle twitching when tapped, near the zygomatic arch. Trousseau sign, carpal spasm induced by blood pressure cuff inflation. Seizures, due to increased central and peripheral nervous system irritability. Mental changes, depression, confusion, impaired memory, delirium, and hallucinations. Cardiac effects, prolonged QT interval, ST segment prolongation, and torsades de pointes. Respiratory effects, dyspnea and laryngospasm. Chronic symptoms, hyperactive bowel sounds, dry/brittle hair and nails, abnormal clotting. Osteoporosis, bone mass loss leading to porous, brittle bones and fractures. Assessment and diagnostic findings. Serum calcium and albumin levels. Total serum calcium may be underestimated with low serum albumin. Corrected serum calcium is calculated: for every 1 g/dl decrease in albumin below 4 g/dl, add 0.8 mg per deciliter to the total calcium level. Ionized calcium. Ideally measured directly in the lab. Estimated from total calcium and albumin levels if ionized calcium is not available. pH effects. Alkalosis increases calcium binding to proteins, reducing ionized calcium and potentially causing hypocalcemic symptoms. Acidosis reduces calcium binding, increasing ionized calcium levels. Parathyroid hormone (PTH) levels. Decreased in hypoparathyroidism. Magnesium and phosphorus levels. Evaluated to identify causes of hypocalcemia. Symptoms correlation. Assessed in conjunction with lab findings for comprehensive diagnosis. Medical management. Calcium supplementation. Acute cases, for calcium gluconate or calcium chloride for immediate correction. Chronic cases, oral calcium supplements with or without vitamin D. Vitamin D therapy. Enhances calcium absorption. Address underlying causes. Correct hypoalbuminemia, hypomagnesemia, or hyperphosphatemia. Monitor and adjust pH, manage alkalosis or acidosis to stabilize ionized calcium levels. Dietary modifications. Increase calcium-rich foods. PTH replacement. For hypoparathyroidism-related hypocalcemia. Severe cases. Continuous cardiac monitoring during 4 calcium administration. Nursing management. Monitor calcium levels. Regularly assess total and ionized calcium levels. Monitor related parameters like serum albumin, magnesium, phosphorus, and pH. Assess for symptoms. Observe for signs of tetany, Chvostek sign, Trousseau sign, and neuromuscular irritability. Monitor for cardiac changes like prolonged QT interval or arrhythmias. Check for respiratory complications, including laryngospasm and dyspnea. Administer calcium therapy. Administer 4 calcium gluconate or chloride as prescribed. Monitor for complications like bradycardia or phlebitis during 4 infusion. Educate about proper intake of oral calcium and vitamin D supplements. Prevent and manage complications. Maintain airway patency in case of laryngospasm. Ensure safety measures to prevent seizures or falls due to neuromuscular excitability. Dietary education. Encourage intake of calcium-rich foods, e.g., dairy, leafy greens, fortified foods. Promote vitamin D sources, e.g., sunlight, fortified foods, supplements. Monitor acid-base balance. Assess for alkalosis or acidosis and collaborate with the healthcare team to correct it. Cardiac monitoring. Monitor ECG for arrhythmias or changes related to hypocalcemia. Patient education. Explain the causes, symptoms, and importance of early intervention for hypocalcemia. Teach about lifestyle modifications, including regular exercise and avoiding alcohol or caffeine that may hinder calcium absorption. Collaborate with the healthcare team. Communicate changes in patient status promptly. Work with dietitians and specialists for personalized care plans. Evaluate patient response. Regularly assess the effectiveness of interventions and adjust care as needed. Calcium excess hypercalcemia. Hypercalcemia, serum calcium value greater than 10.2 mg per deciliter, 2.6 millimoles per liter, is a dangerous imbalance when severe. In fact, hypercalcemic crisis has a mortality rate as high as 50% if not treated promptly. Pathophysiology. Malignancies and hyperparathyroidism. Major causes: malignancies produce hypercalcemia via various mechanisms. Hyperparathyroidism leads to increased bone calcium release, intestinal, and renal calcium absorption. Soft tissue calcification occurs when calcium phosphorus product exceeds 70 mg per deciliter. Immobilization. Bone mineral loss elevates serum calcium, common in high calcium turnover states, e.g., adolescence or severe fractures. Drug-induced hypercalcemia. Thiazide diuretics reduce calcium excretion, vitamin A/D intoxication, lithium, and theophylline toxicity also increase calcium levels. Neuromuscular effects. Reduced excitability causes weakness, incoordination, anorexia, and constipation. Cardiac impact. Hypercalcemia, greater than or equal to 18 mg per deciliter, may cause cardiac standstill and exacerbates digitalis toxicity. Assessment and diagnostic findings. Serum calcium levels. Hypercalcemia is diagnosed when serum calcium greater than 10.2 mg per deciliter, 2.6 millimoles per liter. Cardiovascular changes. Dysrhythmias, such as heart blocks, shortened QT interval, shortened ST segment, and prolonged PR interval may occur. PTH levels. Double antibody PTH test. Elevated in primary/secondary hyperparathyroidism. Suppressed in malignancy-induced hypercalcemia. X-rays may show bone changes, bone cavitations, or urinary calculi in malignancy-associated hypercalcemia. Urine test. Sulkowicz test, dense precipitation in urine indicates hypercalciuria. Medical management. Hydration. Administer intravenous, fluids e.g., normal saline, to promote calcium excretion through increased urine output. Medications. Bisphosphonates, inhibit bone resorption, e.g., pamidronate, zoledronic acid. Calcitonin, reduces serum calcium by inhibiting bone resorption and increasing renal calcium excretion. Glucocorticoids, reduce calcium absorption in vitamin D-related hypercalcemia. Loop diuretics, e.g., furosemide, promote calcium excretion but are used cautiously after rehydration. Dialysis. Considered for severe hypercalcemia, greater than 14 mg per deciliter, unresponsive to other treatments or in renal failure. Treatment of underlying cause. Manage malignancy, hyperparathyroidism, or other contributing conditions. Monitoring. Regular monitoring of serum calcium, phosphorus, renal function, and cardiovascular status. Dietary modifications. Restrict calcium and vitamin D intake if contributing to hypercalcemia. Nursing management. Assessment. Monitor serum calcium levels, cardiac rhythm, and neurological status. Assess for signs of muscle weakness, fatigue, constipation, or dysrhythmias. Hydration support. Encourage oral fluids or administer fluids to prevent dehydration and promote calcium excretion. Medication administration. Administer prescribed bisphosphonates, calcitonin, or diuretics. Monitor for side effects of medications like bisphosphonate-induced fever. Dietary education. Advise a low-calcium diet and avoid calcium-rich foods or supplements. Mobility promotion. Encourage ambulation or passive exercises to reduce bone resorption in immobile patients. Monitoring and reporting. Observe for worsening symptoms, e.g., arrhythmias, severe muscle weakness. Report any significant changes in lab results or clinical condition. Patient education. Teach about the disease, treatment plan, and importance of follow-up care. Instruct on recognizing symptoms of hypercalcemia recurrence. Safety measures. Prevent falls or injuries due to muscle weakness or lethargy. Psychosocial support. Provide emotional support, especially in malignancy-related cases.